early symptomatic syndromes eliciting neurodevelopmental clinical examinations. And that's what I've created, as it were, as an acronym for the group of children. Essence is an acronym for the group of children who have either autism, ADHD, Tourette Syndrome, bipolar disorder, learning disability, dyslexia, all of the children with learning disabilities who have an onset of symptoms in the first few years of life, and who in the first few years of life are often very difficult to tease out one from another. The type of problem that the child is suffering from can be very difficult to diagnose. And currently, people are over-focusing, I think, on one aspect of all these problems, thinking that it has to be autism, or it has not to be autism, or it has to be this disorder and not that disorder. And so we're opening up services for children for autism, services for children with ADHD, services for children with learning disability, and they're all separate and they come in different boxes, and we have different specialists in different fields looking at the same child with different glasses on. And I think we have to do something about it. Autism, I think, is probably the best validated communication disorder that we know about currently. But I think the word autism spectrum disorder is perhaps, even as everybody's come to accept it, including myself, I think it's a misnomer, because we're dealing with several different spectra, even within the autism spectrum. And so Mary Coleman and myself have proposed that we should be talking about the autisms in the plural, because they're all slightly different one from another. There are some commonalities, but there are also major differences if you're looking at individuals with these conditions. I think the autism may be part of a broader spectrum of empathy problems, where there are several different types of so-called disorders that have a subgroup with empathy problems. That's the inability or the decreased ability to understand the perspectives of other people, and to understand the perspectives that comes from mentalizing about mental states. And the common denominator in the autisms would be this deficit in intuitive empathy, intuitive and active shared attention, and in spontaneous intersubjectivity. And this social communication problem could also be referred to, with Lorna Wing's word, a lack of a social instinct from the beginning of life. Although, of course, we don't know what a social instinct really is. It's something that we don't know very much about in terms of, for instance, brain functioning. If we're looking early in life to discover and uncover the problems that children need some help for, I think we are dealing with a huge spectrum of problems, because on the one hand we need to find the children who have autism and similar problems, and on the other hand we need to find the children who later develop into those people who have problems with their own attitude to society, and the group that we very often refer to, at least in Scandinavia, as the psychopathic group of individuals. These two groups of individuals are very different, usually, one from another, the autism group and the later psychopathic group, but there are very clear markers for both types of problems in the first few years of life. And those markers are not necessarily very different in one group as compared with the other, as I'll come back to. Once autism is recognized in early childhood, say if it's recognized around the age of 3, it is very likely that that person will still be recognizable as having some autistic features or autism by the age of 30. So 30 years down the line, that person will still be recognizable as somebody who once had autism and still has autistic features. So in that sense, it's a very valid concept. The diagnosis of autism around age 3 is likely to be followed by, even if not a clear diagnosis of autism by age 30, certainly autistic features will still remain in the vast majority of cases. Now, psychopathy, on the other hand, the other end of the spectrum, if you will, is usually not recognized as a concept until adult age, but it has very clear early markers in the first few years of life, including extremes of impulsivity, cruelty to animals and other children, and what we sometimes refer to in young children as conduct disorder. And with a much weaker predictive power, oppositional defiant disorder, and ADHD. If we have a group of children with ADHD at the age of 3, 4, there's going to be a subgroup within that group who has very clear oppositional defiant traits. And that subgroup includes another subgroup which will turn out to be conduct disorder in a few years' time. And that subgroup, with time, will very often turn out to have antisocial personality disorder or psychopathy. So these syndromes that I am currently proposing that we lump together for the purpose of finding them at an early age and to give some good intervention at an early age. These syndromes, the Essence Syndromes, the early symptomatic syndromes that will elicit some neurodevelopmental clinical examination, usually before the age of 5, in our Western societies, at least in the UK, in Scotland, in Sweden, in Denmark, Norway, we know that these children now come to attention before the age of 5 in the vast majority of cases, although they're still not usually recognized as having one or the other of these disorders. Very often they're left with, we don't know really what it is. There's nothing like autism here, or there isn't ADHD here. There's something here, but we don't know what it is. And if they're seen, for instance, by a speech and language therapist, it's very likely that they will be called specific language impairment. And then somebody will say, well, he needs some language therapy, or we need to look at him again 6 months from now or next year. But usually it won't be followed up by somebody looking at that child with a view to diagnosing autism, or to diagnosing ADHD, or to diagnosing learning disability. Or that child may come to an autism clinic, and people will say, oh my God, this is autism. And nobody will be looking out for concomitant ADHD in that child, for instance. And we're seeing all over the world how children with autism no longer are diagnosed with learning disability, when in fact their learning disability very often is much more important even than some of the autistic features in that child. And when this starts happening all over the place, so that people are opening up, as I said, clinics for this particular disorder and not for that particular disorder, we're in trouble, because we're leaving out ways of intervening that might be much more helpful if we were taking a more holistic approach and realizing that if you have autism, for instance, by the age of 3, you're almost 100% likely to have something more than autism. You're very likely to have ADHD, you're very likely to have epilepsy, you're very likely to have a learning disability, you're very likely to have a speech and language impairment, and it's very likely that actually you meet criteria for all of those 4 conditions, and that you should have a diagnosis of all 4 conditions rather than just one. So on this list, I've listed the syndromes that currently lead young children and their parents to various specialists before the age of 5. And the children are presenting with various types of problems, including these. General development is usually, or very often, the first indicator that something is amiss with this particular child. And a pediatrician or a GP is likely to be the first person to see that child. Motor perception and sensory problems are probably extremely prevalent throughout the whole group with Essence, and are currently usually missed altogether unless seen by an OT, or perhaps a specially interested pediatrician, or occasionally a specially interested GP. Communication and language problems will very often be seen by speech and language therapists, or CAM services even, pediatrics and neurology. Activity and impulsivity problems usually will be referred, if people see this as the main presenting problem, to the CAMS service. Or if attention is the major problem, maybe a psychologist or neurology, or CAMS again. And social interaction and reciprocity nowadays very often will be directly referred to somebody who's specializing in autism or an autism center, or community pediatrics or CAMS. Behavior, again, CAMS and pediatrics. Mood swings would be CAMS. Sleep, pediatrics and the GP. Feeding, pediatrics and GP and CAMS. But also in child health visiting, in well baby clinics, in preschools and schools and newborn units, and in social work. You come across these children and their parents. In social work, usually the parents, but they have children, and the children have problems. And if we were more attuned to the possibility that if a child presents with a problem before age 5, it usually is a problem. And people have got this old idea that, well, a problem that's reported by a parent usually isn't really a problem, and there's nothing we really need to do about it. We don't need to look one more time. We don't need to think extra about it. Instead, our main purpose, our main goal is to be reassuring and tell them nothing wrong with your child. This very active child running around the room, you should be glad that he's not sitting still and not doing anything. Or on the other hand, if the parent comes to you and says, he doesn't do anything, he's just sitting here, you'll say, well, children are so different. You should be glad he isn't overactive. And come back in 2 years' time or 5 years' time, or we'll follow it up. But usually people don't do anything. And in fact, there's now very good evidence that usually when parents come to you for something with their children under age 5, it is something worth thinking about and something worth doing something about. I've taken an example here from the field of language development, because in the literature and in our own center we've done a number of studies looking at the long-term consequences of having language delay at 2.5. Children with language delay at 2.5 are at greatly increased risk of all types of problems several years down the line. For instance, in the total population study done by Carmela Menescalco in our group, she surveyed 1,000 children plus at 2.5, looking at those who had fewer than 25 communicative words at the time, or were incomprehensible in their language to other people, or where parents reported he doesn't really understand what we're saying. She looked very carefully at all those children. 6% of the whole population actually screened positive for that, and 5% of the population actually did have, according to a Raynell test, a language problem at 2.5. She then followed them up, and various other groups followed them up blindly with a control group to see what happened to them. And at age 7.5, 70% had a diagnosis of ADHD, autism spectrum disorder, learning disability, or developmental coordination disorder, usually combinations of those, plus language impairment. They still had language problems. And those 30% who didn't have a language problem, all but one had dyslexia. So virtually everybody with a speech and language problem at 2.5 has something that's worth looking out for that's not just language. We've also looked at autism at the same age. So I now talk to you about, first I talked to you about children presenting with language delay. Now I talk to you about children presenting at about the same age with suspected autism instead of language delay. So these are children being referred somewhere with a suspicion of autism. And what happens to children if they're under 3 when they are suspected of having autism? Well, 75% 3 years down the line will still meet full criteria for autistic disorder, but the remaining 25% will meet criteria for either another autism spectrum disorder, ADHD, or a learning disability. And that's quite regardless of whether we are looking at 28 children as we did 25 years ago, or almost 210 children as we did last year. So we have the same findings now as we did 20 years ago. A diagnosis or a suspected clinical diagnosis of autism by the age of 3 is likely to be autism or another major neurodevelopmental disorder several years down the line. So the risk of false positive diagnosis, if you will, of autism by the age of 3 is minimal. Minimal in the sense that, well, it might not necessarily turn out to be classic autism, but it will turn out to be a neurodevelopmental disorder that's in need of some kind of intervention. So what are the symptoms of autism or autism spectrum disorder before age 3, 4, 5? Well, actually, if we look at the literature, we can find very good evidence that in many cases, motor control problems are the first recognizable signs that there might be a later diagnosis of autism in this child. For instance, the Möbius-like face, the face with no movement, the face that looks very serious, the face that doesn't really have much of movement in it, is very typical of perhaps even a majority of children with autism, although the samples that have been looked at so far have been very small. But those who have been looked at have had this particular facial appearance of very little movement, almost as though the facial nerves were paralyzed. They also very often have very strange patterns of moving from back to front and a very compartmentalized motor development, so that the motor development comes in chunks rather than gradually with several things happening all at one time. There's one thing at a time that happens over development in autism. Perceptual abnormalities are common and perhaps present in almost everybody with autism, and certainly in our follow-up study from very young age to over the age of 30 in Gothenburg, this is the most consistently reported problem that will remain 30 years later. So if a child has autism under the age of 10, usually there's some kind of perceptual abnormality with strange reactions to sound or touch or heat or cold or whatever. If you follow that individual up 30 years later, there will still be major perceptual sensory abnormalities reported about this individual. The most stable of all the signs or all the symptoms in our follow-up study, even more stable, although at about the same level as the social communication deficits. Language problems are present, of course, in the vast majority. Even in those with Asperger's syndrome, there are language problems in terms of how you use language and pragmatics and the tone of voice, the pitch, etc. And the first words are usually not the words you would expect them to be, etc. So it's not right to say that individuals with Asperger's syndrome do not have any speech and language problems. They usually do. But of course, it's only by the age of 2.5 or around that age that you can actually say very safely that this is a language problem. Before that age, it's much more difficult. There are behavior problems in the vast majority. There are no or limited joint attention, but it isn't as people were expecting like 5 years ago. Everybody expected now we have joint attention to pick everybody up for autism around the age of 10 months. But you can't use joint attention for screening for autism at 10 months because children with autism can very often engage in joint attention. What they don't do is initiate joint attention. So if you're looking for self-initiated joint attention, maybe, but if you're looking at any kind of joint attention, that won't pick up the vast majority of individuals with autism. Hyperactivity and impulsivity are extremely common, and 40-50% of all with autism present actually with hyperactivity. And I would put it to you that if you see a child under the age of 3 with extremes of hyperactivity, your first thought should be autism rather than ADHD, because children with ADHD without autism don't usually present with extremes of hyperactivity at that age. The combination of severe learning disability and autism under the age of 3 usually is also, or very often goes alongside with extremes of hyperactivity. Hypoactivity could be the presenting symptom in 1 in 10 to 1 in 4 children, and sleep problems very often are the first reported symptoms, although they're very unspecific and so many children suffer from them. You can't have it as one screener, but at least you should listen very carefully to parents who say, my child has a 6-month standing problem with sleep or more. And again, delayed general development is a common presenting problem, but it's not nowhere near as common as we used to believe. Only 10-15 years ago, everybody said it's like 80%. But of course, with a broader view of what autism is and what it's not, we now know that probably no more than about 1 in 5 of children with autism actually do present first with delay in general development. Mood swings are present in about 10%. And one or several of these could be the presenting symptom. Now, what about if we look at ADHD with oppositional defiant disorder? What are the main presenting problems in that group? Well, actually, exactly the same, except perhaps the joint attention, self-initiated joint attention, which hasn't been reported to be a presenting problem in ADHD. However, these figures are actually very close to what I just showed you for autism. So you can't really say if a child presents with combinations or 1 or 2 of these problems that, well, that's an indicator it has to be autism, or it's an indicator it has to be ADHD. Well, it's probably an indicator that it has to be something, but it's not necessarily autism, it's not necessarily ADHD. It could be Tourette Syndrome, it could be a learning disability, it could be one of the other disorders that was listed on the first slide of Essence. I do agree that this isn't... Where should I point it in?
I'm not sure, I'll ask the technicians. Where should you point the note?
Well, anyway, now it's at least functioning. I was mentioning before that I think it's important to find children with autism and children who are at risk for later antisocial development, which these are extremes. On the one end, the autism group, on the quite opposite end, those with antisocial development, because as you know, individuals with autism have a very low risk of developing into what we consider to be antisocial people. They have social problems, but they're not antisocial in the same sense that we consider so-called psychopaths to be. But we know that childhood ADHD, diagnosed at about 5 years of age, when untreated, leads to a 20% risk of antisocial personality disorder, which is very often equivalent to what people call psychopathy. ASD has very little or perhaps even no risk increase compared to the general population, perhaps even a decreased risk compared to the general population for antisocial personality disorder, except when it's combined with ADHD. Interestingly, when ADHD is combined with developmental coordination disorder, when children who are hyperactive, impulsive and inattentive also are motor clumsy, they have an extremely high risk of being in the autism spectrum. So the combination of a presenting symptom of ADHD and motor clumsiness in the child should immediately alert you to the possibility that this child might actually also have quite marked autistic features and that the autistic features might need extra intervention. So DCD, developmental coordination disorder, or motor clumsiness could be a marker for empathy problems. Whereas ADHD without DCD, if ADHD is not combined with DCD, as is the case in about 50% of all ADHD cases, about 50% have motor clumsiness in an ADHD group. The other 50% don't, and the 50% who don't, they are the ones who are at risk for antisocial development. So what is the scope of the problem of Essence? Well, at least 5% of all preschool children and school-age children have child neuropsychiatric problems such as ADHD, autism, tic syndromes, etc. And probably about 7% of the boys and 3% of the girls have these problems, but the vast majority of the girls are not diagnosed, not recognized. They're being treated as family relationship problems. She's just a bad girl, she's strange, she's odd, she doesn't do what we want her to do, she's avoidant, she's demanding to be on her own, she can do what she wants, all of these things, but nobody makes a particular diagnosis. And in a large study done by Svenny Kopp in our center, looking at 100 girls with social and or attention deficits, she found that the vast majority actually did have either ADHD or autism spectrum problems, and usually they had not been diagnosed. But these girls had been diagnosed with pathological demand avoidance syndrome, or they had been diagnosed with depression or anxiety, or family relationships problems, or reactive attachment disorder, but they weren't diagnosed with ADHD and autism. So we believe that actually the difference between the gender isn't at all as great as is reported in the literature. We don't believe any longer that there are 4, 5, 6 boys to every girl with autism. We believe that there are many girls undiagnosed out there in society with autism spectrum problems, and that with time, say if I were here again 5 years from now, people would have started reporting that actually the difference is more like 1.5 to... I can't accept that this is going... I have to have 10 more minutes because I was allowed 40 minutes on the program, so sorry about that. Anyway, it's a huge problem. This is a common problem. It's common both in boys and girls. And we can't sit back and relax and say, well, let's just wait and see. There's nothing we need to do about this. We have now come to the conclusion that autism is about 1% of the general population. Yes, and that's fine. Lorna Wing said so a long time ago. We did as well. Nobody believed us. But now, of course, everybody believes that this is true. I'm now putting it to you that another 3, 4, 5% have problems that need to be attended to, not exactly in the same way, but at least from a neurodevelopmental perspective. We need to look at a much larger group of children and understand that there's great overlap between these conditions, and if you have one, you're likely to have more than one. So it's a public health problem. And we know that it makes a difference. We know now that it makes a difference to have an early diagnosis of autism and to have some intervention. It does make a positive difference. That is proven beyond any reasonable doubt, even though it's nowhere near clear exactly how much help is needed and what is needed. There is evidence that if you do something after an early diagnosis, outcome will be better. The same holds for ADHD. The same holds for oppositional defiant disorder. And so this is a time when we need to actually do something about young children's mental health, rather than saying, let's wait and see, let's wait to have them fail in society, and then we'll do something about it. Please look out for children with Essence long before that, and maybe we can stop their rather depressing outlook or prognosis. And if we look at teenage, we have almost double the numbers, because more cases are being recognized after the age of about 10. And when you look carefully at children with depression, anxiety, as I mentioned, in particular perhaps in girls, you'll see that, well, actually underlying these problems are very often neurodevelopmental essence problems. So I'll just give you autism as an example of essence, rather than seeing autism as a very specific condition which is separate from all these other neurodevelopmental problems. It is probably 1% or a little more actually of the general population, but of course it depends on exactly how you diagnose it. So if criteria change, prevalence will also change. Half of these children, according to the Stockholm study I was referring to, are recognized under the age of 6. And the main presenting symptoms, as I told you, are motor perceptual, sensory, attention, activity, learning, sleep, social, and language, probably in that order. So if you want to pick them up even earlier than we do today, you probably would have to be much more carefully looking at the very early motor and sensory development of the children. Now, what are the coexisting disorders in autism? I told you that if you have a diagnosis of autism, you also have another condition. Almost certainly you do. Epilepsy occurs in about 20% throughout the spectrum, and in classic autism it's extremely common, and new cases actually emerge after the age of 30, after the age of 40, even after the age of 50. So if you have a diagnosis of autism, you have to watch out for epilepsy throughout the lifespan. Other medical disorders are currently present at about 20% of all cases, at a rate of about 20% of all cases, but this number is growing every month, because we are currently, of course, discovering new syndromes almost every day, as the new genetics will provide us with more information. Several of these new syndromes will be branched off and be named after their genetic problem, rather than as part of the autisms. It will still remain part of the autisms, such as Fragile X syndrome, which is clearly part of the autisms in the sense that Fragile X syndrome very often causes autism. ADHD is very commonly present and should be treated in many cases where currently it's not treated, although it has to be said that many young people with autism who are hyperactive will not be hyperactive once they receive appropriate intervention. When they come to a structured environment where they can foresee what's going to happen to them, when they can communicate at their level, etc., their hyperactivity usually subsides. But there's a subgroup of about 25% where the hyperactivity and inattention doesn't go away, and you will need to think about treatment for that group. Tic disorders are very, very often present, and they are perhaps indicative of a slightly better outcome, which is surprising. Catatonia, bipolar disorder, anxiety, all of these are very common. And no coexisting disorder I have put up here as 0%. So what does it mean? Well, it means if you have somebody diagnosed with autism, you immediately need to start thinking about what can I do to discover all the other problems that this person is probably suffering from. So what is autism then? Autism is a group, not one disorder. It's a group of disorder, a group of multifactorially determined conditions. It could be due to prematurity, it could be due to thalidomide exposure in pregnancy, it could be due to genetic factors, it could be due to the combination of some genetic factors and some other environmental factors. It could be due to very specific genetic disorders. And we know now from many, many studies that synapse and clock genes probably play a major role in the majority of cases. We showed almost 10 years ago in Nature that neural ligands are sometimes mutated in autism, and other groups and ourselves have also then shown that other synapse genes like neurexin, the SHANK3 gene for instance, are not very often, but sometimes mutated in autism. Melatonin genes are also quite often mutated in autism, but they're also mutated in ADHD and in the other Essence syndromes. We know now that the prefrontal temporal brainstem and cerebellar regions of the brain are very often, perhaps usually, implicated in autism. And these parts of the brain are part of a functional network called the default network, which is probably not normally functioning in autism. The default network is a network which is very active when we are silent and when we sit down and think about the future or the past or about ourselves or our friends, then it's very active. Cerebellum, brainstem, temporal lobes, frontal lobes, the medial portions of these areas are very active when we're thinking, when we're reflecting, when we're looking back and looking forward. Without interacting with other people. The activity in this system goes down when we interact with other people or when we're tested. This doesn't happen in autism. It's a very low functioning system in autism generally, it seems. I won't go into ADHD as an example of autism, but I do understand the previous speaker. But just to say that if we're looking at what is ADHD due to, well, it's due to very similar things. It's just slightly different portions of the brain are involved. But the comorbidities are the same, and they're very underrated in ADHD, just as they are in autism. Oops. But maybe I'll go back to this one to just say that 10 to 20% of all individuals with ADHD, if you're a doctor or a psychologist or a parent attending an ADHD clinic, because your child or the child before you has ADHD, you also need to think the other way around. Well, it's quite possible that there's also an autism spectrum disorder here. 10 to 20% of all children with ADHD have autism or Asperger's syndrome. So we need to, in both camps, as it were, be thinking about the other condition. But as you can see from this long list, you would have to expect just about anything. If you have started your life with ADHD or started your life with autism spectrum disorder, you should expect all sorts of other labels to be thought about and perhaps erroneously attached to you. Because, for instance, personality disorder is something that is now diagnosed in a very large proportion of individuals with Asperger's syndrome once they get to be adults. The same holds for ADHD. And it's the same disorder, it's the same problem, it's the same type of problem that's been present from early childhood that is now being looked at from a different sort of theoretical standpoint. And so these other criteria are used and these other diagnoses are made. But just as in autism, there's almost 100% comorbidity in ADHD. I'll just finish off by getting to Tourette syndrome, because Tourette syndrome is something we very rarely speak about in the field of autism, even though I think everybody who's been in the field for a long time, and you shouldn't be thinking about ADHD until you have excluded the two others. People never talk about mental retardation and intellectual disability anymore, and I'm only mentioning it, which is very typical. We've all almost forgotten about what intellectual disability actually does to people who have ADHD or autism. In fact, I'm sometimes nowadays inclined to say, I'm not so sure autism means a horrible prognosis. I know quite a number of people with very marked autistic features who've done very well for themselves in life. And if we have people with autistic features without intellectual disability, without ADHD, without epilepsy, etc., maybe they do very well. So maybe we should be, again, start to think about what is it that causes a bad outcome in autism, and coming back to maybe it's intellectual disability, maybe it's epilepsy, maybe it's a medical disorder, and never forget about trying to find out about those associated, that we call associated problems, when in fact they might be the most salient ones. I have one more slide that I would like to show. The behavioral phenotype syndromes are extremely interesting from the point of view of diagnosis, and there are several people within the Essence group, of course, who suffer from these Fragile X, tuberous sclerosis, 22q11 deletion, etc. And so people need to think constantly about, is that what underlies this particular type of problem? Oh. Oh, please. I'm sorry about this. I should have taken them out from the beginning, but I was hoping that they might go into the pack of what you get. And the point I needed to make at the end here is that, here it is, finally. All these conditions that I've referred to as Essence, early symptomatic syndromes eliciting neurodevelopmental clinical examinations. They are early onset, they are representative of syndromes, they will lead you somewhere to a clinical expert, and that clinical expert could be anybody from a speech therapist to a child psychiatrist, a neurologist, a pediatrician, a GP, and depending on who you see, you'll get one of the labels. You won't get more than one in the vast majority of cases. You need more than one in the vast majority of cases in order to get the right kind of help. And we need to understand that these are developmental disorders that fluctuate in terms of symptomatology over time. So depending on when you see somebody and what expert you see, you'll get a different diagnosis at one time as compared with the next. For instance, it's very common for children to be diagnosed first with Asperger's syndrome, then with ADHD, and people will then debate, well, is it really this or really that, rather than saying, well, it's actually both. All children presenting with major and impairing essence symptoms, and I've shown you the symptoms, need to be followed up. You can't ever sit back and say, he'll grow out of it. There's no indication whatsoever that children grow out of these problems without help in any large proportion at all. A small proportion, yes, but more than 90% who present with one of these problems as an impairing problem before the age of 5 will have a major problem 5 years down the line if you don't do anything about it. So even though refined diagnosis is very necessary and needed in all cases, at an early stage, Essence may be the only safe label. Thank you.